Hey, thanks very much. It's nice to be up here and know what it's like to be over 6 foot tall. Yeah, this is to remind me, it's not my speech, but more to remind me to keep on track. So when I was asked to do this, I was asked to speak for 10 minutes. And those of you that know me, 10 minutes is quite difficult for me to fit in everything. So it's to keep me on track here. But I want a bit of audience participation to start with, which is just a simple question. How many of you in this room have children? So quite a few of you, okay? So your children, and I know many of you have heard me say this before, your children make up 25% of the UK population under 18. 25%. Now, Rich has talked about Scotland as, country. Imagine children, the population of children, were a country. That is the size of the Netherlands. Population in the Netherlands, 17 million. Population of Greece, 11 million. You're talking about a population that is the size of a country. Yet, how much, and here's the next question, how much investment, digital investment in 2020 went into children's healthcare? Just shout a number. Quickly, because I've only got 10 minutes. 2%. Okay, 2%? Any 5%? Okay, you are still off. It was 0.7%. Of the £21 billion that was spent in the US on digital healthcare, 0.7% was on children's healthcare. Oh, sorry, digital healthcare, which is astonishing because take your children and think about how much time and effort you invest in your children. And why do you invest in them? Because, and this is the strapline, 25% of the population, 100% of the future. Our children today will be what happens tomorrow and the next day and the next day. They will be the healthcare workforce, they will be in education, they will be in industry, they will be in the public sector, and so on and so forth. All of them will contribute to what happens in this country in the next 20 years. Yet we invest very little in their health. We invest a reasonable amount in their education. As parents, and I have 3 children, we invest a lot of our time and effort to make sure we get the best for them. But when we look at health, we don't do that. Okay? So, what we need to do, and I'm glad to hear the word prevention is mentioned, because we have a disease model in healthcare. We have a disease model that treats illness, but we don't have a good model for prevention. And if you're going to prevent problems, you don't prevent them when you're 50 or 60. You prevent them in childhood. Because the diseases that we see in adulthood, are the diseases that start in childhood. So, to give you an example, take smoking. There aren't many adults that start smoking in their 40s and 50s. Teenagers smoke, and sometimes younger, unfortunately. Obesity. We're seeing a major problem now. It has its origins in childhood, and therefore heart disease and stroke and diabetes and cancer all have their origins in childhood. They don't start, they manifest at 50, but they don't start at 50. So everything that we do with regards to the health of children will have a knock-on effect in the future. Yet I go back to that statement of the investment is so little, it's pitiful in children's healthcare. The nice bit about it is that most children are healthy. But actually, by the time they get to their 50s and 60s, they aren't healthy anymore. And we look back and think, if only we had invested some time and effort in the health of children, perhaps we wouldn't be dealing with the problems now. And it's the old Einstein statement, madness or insanity is doing the same thing over and over again and expecting to get a different result. Yet we are still investing the same amount in children's healthcare over and over again and expecting that something is going to change in the future. So if we're really going to get it right through innovation, through technology, it's starting in childhood. It's not to pull away from adult healthcare, but it's about rediverting the money into children's healthcare, in prevention and treatment, to make sure that our population doesn't utilize or overutilize the health services of the future. There are challenges in pediatric innovation and technology development, because when we talk about technology development in cardiology, surgery, we're talking about disease, or we're talking about specialties. When we talk about children, they are not a specialty. I work in pediatrics, but pediatrics actually describes a population. It's a population of people. Pediatric endocrinology describes the specialty I work in. But one of the challenges we've got as we move forward is that we are developing technology for child health. Not child disease, child health. But it's a population. So we have to think differently. We have to think about how do we keep them well as treating the disease? How do we deal with the diversity of childhood? What happens for a baby is not what happens for a teenager, because children, they grow, they change physically, and they change mentally and psychosocially. So everything we do around innovation has to be versatile. And not just versatile from the perspective of age and development, but also versatile in terms of the dynamic. Because when we develop child health technology, we sometimes actually develop technology for the family and the parents. But as children mature and they grow older, then we develop technology for adolescents. So there are challenges in that flexibility and versatility in child health technology, but also challenges in keeping young people engaged as well. There's also challenges around perception. Pediatrics is perceived as a small specialty. It's not. I've just said to you that the population of children in the UK, 18 and under, is 25%. But the private sector has traditionally perceived pediatrics as, or the population of children in pediatrics as a specialty, as not worth investing in. Now imagine people said to you, your children are not worth investing in. You would be appalled by that statement. But actually, it's now time for the public sector and the private sector to wake up and say, we need to invest in the health and healthcare of children and young people. And we've got to also stop making the mistake that the pharmaceutical industry made many, many years ago, not purposely, but repurposefully. What they actually did was said, we've got medications, children are smaller, why don't we do something really clever and make the medication smaller, or a smaller dose? With no bearing on physiology, anatomy, and development. And it didn't work very well. It did in some cases, and it didn't in others. But actually, repurposing has a purpose, but often repurposing from bigger to smaller doesn't work very well. So I'll give you an example, and there's a positive slant to this. This is not a party political broadcast for children. There is a positive slant to this, because I do a lot in this field. But to give you an example, so a colleague of mine from Sheffield Children's Hospital, Professor Heather Elphick, she took really what was a significant problem and made a solution that actually, on the face of it, was really simple, but she couldn't have done it without the innovation and technology that exists today. So I'll tell you the problem. She looks after children that have non-invasive ventilation. So these are children that have muscle disorders, their muscles are weak, they require ventilation overnight at home. These are clever machines, they push oxygen in to keep the lungs open. The problem was that the mask that was made was repurposed from an adult mask. It was made smaller. How many of you have young children? What's the shape of your child's face? It's round. What's the shape of an adult face? It's long. So you take a long mask and stick it on a round face. It doesn't work very well. So the problem then is you get a bad seal. And then when you get a bad seal, the machine detects a bad seal and it alarms. Okay, so it alarms, so what? That's good because it detects a problem. Until that goes on and on and on and on through the night. And imagine one night of a machine alarming and then do that for 365 days a year and then for several years. You're tired, you can't work properly, your kids are woken up because the machine is alarming, so you try and find a solution. And the solution was simple. It really was simple. You tighten the mask and you get a seal. Except there was a problem. When you tighten a mask on a child's face and the child's face is developing and growing, it deforms. And faces they were getting terrible problems on their face with pressure sores, and as the face developed, the face was getting pushed to one side as the seal. So it's not a good solution to a repurposed technology. Now, what we can do is we can 3D map the face. So what Heather and her team did was they took a facial topography, or a facial map, scanned it, and then took that and developed the mask to go onto the face. And so it was perfect. It was a perfect solution. You could map a child's face, you could create the perfect mask and seal, and you got rid of the problem, which was the alarming and tightening the mask. But better still, when the child's face changed to elongate as an adult face, you chuck the mask away and get another one. Perfect solution to a problem. And these problems exist right the way through the NHS. These, as Graham has quite nicely described, well, we've always done it that way. It's been a bit of a problem. We've accepted it. Well, we don't accept it anymore because actually we've got stuff, technology that changes that. And we talk about digital, but actually this digital is big. It often describes data. There are many technologies that will sort problems out that, going back when I was a medical student, were science fiction. They weren't real. I'll give you another example of delivering children's healthcare in an exciting and different way, but doing the same thing. So we had an idea to use virtual reality to deliver physiotherapy. So and here's the problem. Children get bored really easily. And, my kids do. I mean, they often, you're very nice and you're listening to me. My children would not listen like this for a long period of time. But we had children they had upper limb injuries or burns or they had surgery and they got bored of doing their exercises. And, physiotherapists, you'd go to see the physiotherapist, or they would go and see the physiotherapist, and the physiotherapist would say, we want you to put your hand behind your head, we want to scratch your head, touch your nose. The great one was, behave like a tiger, so you have to do this. And actually, if you're 13, 14 years old, you don't want to behave like a tiger. You kind of feel like you've been belittled. And so what we did was we worked with Sheffield University, and we said, well, surely we can do the same movements in a game, a virtual reality game. And so the really clever guys at Sheffield University worked with the physiotherapists and developed a game that basically emulated every movement that the physios were trying to do, but in a virtual environment. And we tested it with healthy children and then moved into the virtual world with children with injuries. And it worked. In fact, not only did it worked too well, because we went from a problem of getting children to engage with them to not being able to get them off the game. They wouldn't stop. We say, look, you've done 20 minutes. They engaged. They were really... But the best story was a young man that was very sadly burnt, who said, very badly burnt, who had not engaged at all, got on the VR game, said, I would do anything like this. Pain had gone, didn't get bored, he totally engaged. So we're using technologies to deliver healthcare in a different way. And some of these technologies really work for children. They really engage with them, and we can improve healthcare in ways that we never believed we could do before. But better still, and this is in the lifespan of this project, the virtual reality headset was connected to a laptop when we started. I think now take it home. It's no longer connected to a laptop. We can put the game in the headset and off you go. And that moves to the next point, which is about how we deliver healthcare. And Graham has spoken about this already, but how we are going to deliver healthcare for children and young people in the future is going to be different. And it has to be different. Because all of you with kids, and all of you that plan to have kids, you will want your kids to get the best education possible and the most engagement in social settings. You don't want to, if you've got sick kids, you don't want to come to a hospital. They spend forever back and forth. That's not great for kids. And in fact, if you keep them in the community and at home and in schools, their education is better and the potential for the future is better as well. So we now need to think of ways in which we deliver healthcare in a different and exciting way. And there should be an expectation for that. Everyone in this room should say, I want different healthcare for my kids. I want them to be healthy as adults. I want those that have diseases and other healthcare issues to be treated in a different way. I want them to get the best education. We shouldn't be bringing children into hospital. We should be delivering healthcare in a way that is still of a high quality, but is delivered in a much, much different way to the way that we have delivered it in the past. And of course, children engage with technology. My kids, we talk about the iPad and the, moving it, but, my kids, when they were 2, were kind of doing this on screens. It was the television, but, it's a good start. But that's what they were doing. There is an expectation. But that also comes with a health warning. Not all technology is likable. And if you ask young people whether they like technology when related to healthcare, some will push back and say there are issues. There are issues around data. Young people don't like the idea of their data going elsewhere. There are trust issues about who has developed the technology. And there are also issues about whether that technology is good enough. So an anecdote, one of my colleagues that owns a company had run a trial looking at a watch with biosensors. Adult uptake was fantastic. And she said, well, we'll rerun the trial with adolescents. And she thought, brilliant, they'd love the tech. Uptake was terrible. And she went back to some of the young people and said, why are you not doing this? Surely you love tech. It's really exciting. We can measure your heart rate and your respiratory rate and all these sort of things with these sensors. And it was on a watch. And do you know what they said? They said, we don't like the watch. It's not an Apple Watch. That's all it was. But there is something about liking technology and also about how your healthcare is perceived. So many young people don't like apps on their phones. We love apps as professionals because they give you information and they interact. But actually, as soon as you put an app on a phone, you change the perception of the child's perception of themselves and how others perceive them. So if kids at school, my son gets a bus home and they don't talk anymore. They just sit there on their phones. But you can see each other's phones. If you've got a healthcare app on your phone, you're different. So we need to, and the positive side to this is that we need to, and we do work with young people to develop technology. And our ethos is healthcare technology designed for children with children. And it's as simple as that. You get children helping to develop the technology, it's much more likely to be integrated into a healthcare system and used than entering the valley of death, of technology valley of death, and being rejected. And there's also a part about working with those that are service providers to ensure that those technologies fit within the clinical pathway and that both those groups, the users and the providers, trust the technology for whatever reason that technology has been developed. So to bring all this together, our journey started about 2014. And it started with me bringing together a group of colleagues and saying, got a bit of a problem here. Child health technology, it's fragmented. it's developed in trusts, sometimes at best regions, and very poorly spread and adopted. But there's some great stuff out there. There's no doubt there is some great stuff out there. How do we address this? And also, how do we start to work together to create a scalable opportunity? Unmet need. Okay, the needs are out there, but how do you change the perception that industry doesn't see pediatrics or specialist pediatrics as too small to invest in, and work together to say, actually, there are so many of us working together around unmet needs that there is a scalable offer there from children's hospitals and children's healthcare. And so I worked really with other hospitals, just went around the hospital and said, what do you think? Should we work together as a network? And I was pushing against an open door. What happened after that was actually I could not have predicted, which was the whole network grew really quickly. We started with the TITCH network, Technology, Innovation, Transforming Child Health. I like to think I might have been influential in the name, but so we started with the TITCH network. And what we did was quite simple. We brought together groups of people from different sectors, including children and young people, to focus on unmet need. Categorise the unmet need, got rid of the noise, people saying, I'd like you to sort out my hospital internet system. I thought, well, I'm not a wizard, so I'm just a doctor, so can't sort out your internet system. But what we did was we categorised those unmet needs and came up with some areas we should focus on. One of them was self-care and independence, about children looking after themselves, and also the issue of remote monitoring. And then we worked with funders, and we said, if you're going to fund child health technology, don't bolt it on to an adult call, because nobody gets interested in that. Do a paediatric call. The other thing we did, and this is my plug for the Yorkshire and Humber YHAHSN, because actually they were instrumental in starting this process, was we received £50,000 from the Yorkshire and Humber YHAHSN, and that paid for a programme manager for the TITCH network. And believe me, when you're working in healthcare, having someone that can do stuff for you is really, really important. So we've got a programme manager. We worked up a funding bid with the NHS England around self-care and independence for children with long-term conditions, and we leveraged £4.2 million of funding for child health technology. And that's where it kind of catapulted what essentially was me working with colleagues to actually, this is an area that needs some focus. And then we've gone on to get funding from the National Institute for Health Research to support the NIHR Children and Young People MedTech Cooperative, which is a consortium of 7 centres across the country, each with a key opinion leader on a clinical theme around technology development. And I'm not going to list the 7 themes because I'll only get to 6 and I'll forget one of them. But we have done some incredible stuff, not because I'm doing anything incredible. It's just great to see people working together to look at healthcare in a different way and to really focus on the needs of children and young people. So I've only got a short bit of time left, but I just wanted to finish with a message that's very topical at the moment, and that is, Boris Johnson today at the Conservative conference has talked about levelling up. Okay, so we talk about health inequalities, and there is a north-south divide. There is no doubt about that. There is a north-south divide. But actually imagine if governments talked about levelling up paediatric and adult healthcare. That actually it was no longer just about the inequalities between parts of the country, but inequality across the life course. And that what we did, or what we do in the future, is we level up investment in prevention and healthcare for children and young people. And we do that in a way that inspires innovation and technology-based healthcare for young people. They would be healthier in the future. They would live longer and healthier. Our healthcare systems would be less burdened with disease. They would go to school more frequently because they were a healthier population, and society would be wealthy as a consequence of that investment. So maybe it's now time to level up between paediatric and adult healthcare, not just to level up regionally, because some regions are worse off than others. So to finish, go back to that title, future of Fallacy? Well, of course, children, as I've said before, children are the future. If we're going to get healthcare or healthcare innovation and technology right, we invest early and reap the benefits later. Thank you very much.
Yeah, Paul, I know you spoke at length earlier. You were talking about this adoption rate in children. I'm interested to see whether you think that so the example that you gave about your friend's company and a watch, it's not an Apple Watch, do you think we have that adoption challenge the other side of that 18 kind of age bracket, i.e. that adults in their young 20s or 30s go, I don't really like what it looks like, but I understand the value of how important this is to my healthcare, whereas kind of pre-18, where they're old enough and they're conscious of their friends at school and how cool things are. Do you think we have an adoption challenge there in children?
There is an adoption challenge across healthcare generally. Spread is difficult, and it's one of the things that has vexed us, even with a consortium that works together. If we develop something, how do we get it to another place? How do we persuade other trusts that it's the right thing to do? And part of it, so there's two sides to this. There's the clinical side and there is the service provider, service user side. So the clinical side is about trust. In fact, they're both about trust, but in different ways. Clinicians, healthcare providers like evidence. We like to know things work and we like to see the evidence to say, yeah, this does what it says on the tin. It delivers what it's supposed to do. We like that evidence. And we also like to mitigate risk as best as possible. We like to say that we've adopted something with minimal risk and it's delivered. That's the kind of desire. The second challenge, and a big challenge for adoption, is integration. How do you get something that does what it says on the tin, but does it do what it says on the tin in the place you put it in? Okay, so you can develop the best sports car in the world, but you stick it in the desert with loads of sand, it's not going to run. You put it in the wrong place. And this is part of the issue of developing something for a clinical pathway, is that you need to work with the healthcare professionals to ensure it fits and doesn't get spat back out. And it's not that the technology was bad, it's because it didn't fit for whatever reason. And so it goes back to Graham's point of saying, it's that persuasion to work with people to make sure that they understand how it works within a system. And those systems are big, what are termed innovation systems. There are systems around procurement of that technology. There are systems around clinical and service integration. There's about home integration. There's a bit about trust. There's also the wider environment. How does your technology impact on what else happens in the hospital as well? So there's lots of parts to that. So that's the kind of clinical side to the adoption. The adoption on a patient side is really about whether that technology is of benefit and actually, is it easy to use? And ease is really important. So we all like technology in some sort of way, our mobile phones and everything else, but actually we like them to be easy. And companies work very, very hard to make sure that technology is user-friendly, and it's very much a buzzword. And healthcare technology has to be the same. It has to be engaging, it has to be user-friendly, and it has to be seen to have purpose. So when I open my smartphone, I'm doing that for a purpose, whether it's buying something or getting information, finding out whether it has a purpose. And there is a value to my life built within that purpose. And that's how health technology and digital engagement has to be. There has to be a purpose. Now, I just wanted to pick up one other thing about adoption, and Graham's mentioned this already, and it's a hugely important area, is about this digital divide. And I heard a group that are based here, someone speaking on behalf of Habitat. They're based in Leeds. And they said something that was really quite profound and quite simple, which is they said, when you develop a technology, make it as it's for the simplest use possible. In other words, don't make it all singing, all dancing. Work on the principle of the person that is going to struggle with it most, and that's where you start from to avoid that digital divide. But the digital divide is complex. It's partly about digital literacy, and Graham's touched upon that already. There is a money side of things there. So, okay, lots of people have mobile phones. Not everybody has a smartphone. Then you get to tablets, less people have them. You get to laptops, even less people have them. But there's also a bit about data, which people forget about. When I download something, it costs money. So I pay a tariff every month to have my mobile phone and Wi-Fi. Some families can't afford that. They do pay as you go. And then you say, download an app, and I want you to turn that app on a network, and input your data. And suddenly they see the pay as you go do, 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 do. Yeah. And they think, actually, I'm not going to use that anymore. So there is a cost side to it as well. So there is accessibility and affordability there, that you've got those factors that will drive that digital divide. So we have to work hard to make sure that if adoption, going back to your point about adoption, is that adoption is to the widest population possible that has value to that population. You know, we invest in things with value, and people invest in things that add value to their life. So yes, of course, there is the kind of, does it look good? Does it fit on my phone, etc.? But there is something about benefit, and people do things for benefit. And the other thing is about that trust in data. So people give away their data second by second every day. As soon as you accept cookies, data is just gone. But actually, people are very untrusting about giving their health data away until they understand the relevance for it. So again, it's about developing that engagement and trust that supports people for adopting something. And the last point on that is adopting doesn't necessarily mean using. If I go out and buy a smartphone that does everything, doesn't mean I use it, just means I've got it. Okay, so there is a piece beyond adopting to say acceptance and engagement, that actually those people beyond adopting it are using it for the purpose it was built. And better still, actually using it beyond the purpose and feeding back to us and saying, that clever thing, well, I can do this with it now. And then we start to iteratively learn and develop those technologies for the future.